Can you hear us? Oh, the guy's gonna have an ortho.
Out in the West Texas town of El Paso, I fell in love with a Mexican girl. Nighttime would find me in Rose's Cantina. Music would play and Felina would whirl. Blacker than night were the eyes of Felina, wicked and evil while casting a spell.
Dr. Raja, can you hear us?
Yeah. You guys, can you hear me?
Yes, and we can see you. Please go ahead. Welcome back.
Wonderful. Thank you. So let's start. Let me have a slide, please. So this is a 77-year-old gentleman who has a very advanced diabetes, hypertension, coronary disease. Actually, he has lost his left leg about a few years ago. Actually has above the knee amputation. And now I saw him like a couple of days ago. He has developed a very painful right grade 2 wound, ulcer. We did some non-invasive studies, and they were very, very abnormal. So we brought him to the cath lab today.
So, Raja,
So I'd like to show you, yes.
how long ago was the amputation on the left?
How long ago? I think it was like 3 years ago.
Yeah. So he's just following statistics within 3 to
also
5
had-
years, getting amputation on the right contralateral leg.
Correct. And he also has like stage 3 kidney disease, and we've been hydrating him. His GFR is around 50 or 45. So let me show you the images. So as usual, we took antegrade access. Actually, I usually go to the SFA rather than common femoral because it's easier and you don't struggle with the wire going into your deep femoral profunda artery. And then after putting a 5-French sheath in it, here you can see that, again, very calcified. This is an angiogram which shows mild to moderate disease SFA. As you know, that most of these people have tibial disease with CLI. And this is my, as you can see that SFA stick is usually low stick, but we have a data. I've done more than 1,000 cases with SFA, and they're very, very safe. And this is 645 sheet here. Now, this is the issue here. You can see that all the tibial vessels are occluded, and there is a collateral filling of the peroneal artery. Going down, if you take a look, it's a single vessel peroneal artery which is going down, and also a pretty severe small artery disease, but most of the flow is coming from this peroneal artery. So far what I've done is I've gone into some MAG, trying to see some different views to see if there is anything I could see here. I tried this is just a 018 gladius wire, which just keeps going into the collateral, meaning that it's a pretty hard cap we are dealing with here.
Dr. Raja, one question. Do you ever consider using CO2 angiography for this case, especially with a CKD 3-4 now?
Yes, I do. But unfortunately, CO2 is not very good for tibials.
Yeah, that's very true. But for the baseline SFA pop picture.
CO2 is, right, yeah, exactly. Usually, all the inflow is usually done by CO2, and then we just do the very, very limited when it comes to the tibials.
Yeah.
I totally agree. And that's, yes, I do it very frequently. So I have now I brought this crosswalk catheter, which is a 018 from Asahi, to see if I can engage at the nub, which looks pretty chronic, and see if I can get through to it. So here, this is my wire, and you can see that I immediately switched to the CTO wire, Halberd 014, to see if that's gonna be helpful. And now I'm just changing my catheter to a different kind to see if I think the most important part is that get to that area. So the plan is, if I am not able to get through to it, then I'll do the peroneal access retrograde. And as you can see, the retrograde cap is very favorable. It's sort of pointy. I'm not sure. It could be very hard also, but that's the approach I think I'm going to do. So I'm open for any comments, anything else. Give me a puff here. So I'm just going to take my catheter and see I can engage. So it's a very strange kind of angulation here.
Yeah.
Mm-hmm.
Let me see if I can do this.
So, Numa, what's your workhorse wire for this? A CTO of the TP trunk to the perineal. What would you use? No.
I usually the CTO wires, there are just few of them. I just go with the Halberd wire 014 or 018.
Yeah.
If that doesn't work, occasionally I might go to Confianza, or all of us have our favorite wires, or 018 Halberd. So you see the problem is here, that it's just the way it's occluded, it doesn't let me hit the, okay, give me another puff here. So important thing is, so now you can see that I am at the cap. And so I'll try to see if this wire goes. But you can see that it's so that this is an area. So you can see a tiny bit of branches, and so I'll just give a little support to this wire.
What support catheter are you using right now?
If it, this is a Trailblazer 018.
Okay. Good.
And this 014 Halberd wire. I think it's not the wire which is a problem, it's just the angle.
Yeah.
And even this angulated, so I can pull it back and see if my wire itself can hit that. Let's do a little road map here. So usually okay, let's try again.
Yeah.
No se mueve la pierna, señor. Okay. Está bien, está bien. Okay. Okay, we'll do a road map, and I'll, rather than injecting too much contrast, so here.
Yeah.
So I'm not even sure it's not going.
Yeah.
It's just a horrible angle. So I don't think we were going to be successful.
So the technique that I've been using, yeah. So one technique that I've been using like this, where you have a shorter nipple, is I go with a 018 Ruboglide, and then just loop it high on the vessel, then just push it with a support catheter. And typically, if you're not suboptimal, you go in right away. So it's what I call it my loop wire technique, and it works. You give it a try.
I do the same thing with a V18, actually,
Yeah.
and a CXI crossing
Yeah,
catheter.
right.
And the crossing catheter you have is angled, just if you do want to, I mean, I don't know if it's worth opening another one, but once you're in that segment, a straight would be better.
Yeah.
You know, because that's hurting you as well. And then if the sheath can come down any lower.
The only reason I picked the 018 from Terumo is because it's very safe. I'm not going to break that wire.
Trying to do a subintimal angioplasty, correct?
Sort of, but start in the true lumen and you'll be surprised. I was a lot of this, they stay intraluminal.
Because if you go with a glide path wire and then you loop it, it's not going to stay in the lumen for sure. It's not going to break the cap. You're going around the cap, correct?
Not
And
this,
you're hoping is that you re-enter into the lumen.
yeah. The whole idea is just put it on top of the cap and then push the cap down with your catheter, with the wire.
Yeah. So, of me here, I try not to loop the wire. I think here.
Which I think we created a
I
channel.
think it has to go, yeah, it has to go
Okay,
straight.
so I think
Maybe switch out
we're
for
gonna
a
get
straight crossing
peroneal
catheter.
access.
I think the angle.
The
Eric,
angle's hurting you.
what do you want to do, Eric? Can you do anything differently?
Yeah, I agree. I think the angle of the catheter is not in your favor, and so it's biasing it towards that lateral wall. I would turn it over, or I would put a sharper bend on the wire and angle it more medially, if you want to stay with the straight wire. But I also use a loop wire frequently, whether it's a V18 or a Gladius Mongo. Once you break through that cap, and it'll just push down through there. And if the loop stays tight and it doesn't open up as you push it, then you're within the confines of the vessel. If the loop starts to open up as you're pushing it, then you're probably in a big subintimal area and you just need to pull the wire back. But I would do a looped wire technique here.
Sid?
So I agree with a lot of the things that have been said. Typically, I cross these with 035 catheters. Why? Because if you think about it, I mean, his catheter is 018. That's a decently sized TP trunk or whatever the occlusion is. The ability to find a softer spot, even on the cap, is much bigger is if you have a bigger catheter. Why? Because an 018 catheter will give you a small loop when you rotate it, whereas an 035 catheter will give you a much bigger loop. So first of all, I think the catheter needs to be a lot closer to the cap. Because right now you've bent that wire and you're kind of trying to poke through the cap. So it gives you a lot more penetrating power. The wire does what it's supposed to do if your catheter is a lot lower, number one, closer to the cap. I agree with what's being said. You want to try to stay true lumen as much as possible. Keeping the size of the loop small will kind of help that. I'm traditionally trained IC guy, so if you can keep it true lumen, if you feel like you cannot break through that with that combination, then you do what's called in the coronary literature the scratch and go technique. You take a tip-loaded wire and intentionally scratch the proximal cap to enter the subintimal space. Remove your scratching wire, and then put a hydrophilic wire with a sharp knuckle, and then go down. But I really do think you have to have a catheter that points medially.
The other way, yeah.
Yeah. The good thing here for me is like, even
I'm
if
just
you
going
go...
to give a little more try, as Eric mentioned, making a little better
That's better.
angle to it. So I did a 2 angles,
That's better.
and actually,
You know, I think the other thing is when you're crossing, to me, it's important to consider what your final strategy is going to be. In this particular location, 100% of the time, I could have put a coronary drug-eluting stent in there.
Yeah.
And so if I'm subintimal, I really don't care because I'm going to recanalize it. And now if you have an occlusion that goes all the way down to the foot and you're trying to stay in the true lumen down there, that's a different story. And probably patency is going to be affected if you're horribly subintimally. But in this particular location, I wouldn't care if I'm subintimal. And it depends on how long the occlusion is.
Yeah, actually, the nice thing about this, Eric, is a very short TP trunk to the perineal, so you can put a scaffold in and get very good long-term results for a bit.
So I
my
would.
hope is whichever way I cross, I will put actually a spree, the bioabsorbable.
Oh, yes.
And
Nice.
and to Craig's point in his wire talk, I mean, I frequently use 2 or 3 or 4 wires for these procedures. I mean, you have one to cross the cap, you have one to slide through the lesion. I mean, you're constantly taking wires in and out and changing the shape of the tip of them. I rarely use just one wire for the entire procedure because the characteristics of the plaque, you're just not going to be successful that way.
We're going to go to the next paper while you're doing this.
Yeah.
Okay.
No,
Yeah.
down, legs back.
Perfect.
Perfect timing. So show us what.
So you guys let me know when you can hear me.
Yeah, we're here. So what did you do to cross the lesion?
Okay, so we did make some progress. I think we left somewhere here. Actually, I took the advice of Eric and made some more angulation to the halberd wire. And as you can see, I brought my catheter, as you said, and to get a more support to the tip. I really didn't want to loop it. That's how I practice. And actually, it started going down, and then so I made a roadmap to direct the tip of my needle, the wire, and as you can see here, right here, a few times I was subintimal. Then I thought I was in the lumen. And here it went into the branch, so that confirmed that, yeah, I am in the lumen. So then I pushed my catheter across to confirm that I am in the lumen. And this is injection from the catheter, which confirmed that I'm in the lumen.
Good job. Yeah.
So at this point, I did an intravascular ultrasound to take a look at the vessel. Luis, can you run the IVUS? So actually the vessel distally is 3.0 and proximally 3.5 going into popliteal. As you could see that there are certain areas of calcification, and again, there are certain areas you can see a soft plaque. So again, it's a mixed morphology. Here you can see that.
Amazing,
So
straight
I
interluminal.
decided to do some debulking for the purpose of, first of all, creating some good lumen. Second is that I'm planning to deliver those bioabsorbable stents. So just to hopefully it can have more absorption. So then after laser atherectomy, this is 1.4 concentric, did two runs. And after the laser run, you can see there's a channel creation. And I already knew the size, at least distally is 3. So this is the 3.0 balloon. How long was it, 60 or 80? So this is 80, 3 or 80, just to see how long I need my stents. And now this is how it looks.
Yeah, that's right.
So I think I prepped the vessel pretty well for stent. I would like to show you these sprees. These are sirolimus drug-eluting bioabsorbable scaffold that comes in different sizes and lengths. The longest one is 38, and the length is from 2.5 to 3.75, correct? Yep. 3.75. So my goal is to put 3.0 and 3.5 to cover the entire area. Now, the question could be asked that how about jailing the AT? First of all, I don't even see it. But then I was talking to them, and in case in the future I have to go after AT, then actually you can go a little higher inflation and you can crack this stent to enough that you can get through to it.
Dr. Raja, great work.
Yes.
Couple of questions. I mean, it's amazing, right? You cross it, you stay interluminal all the way. Amazing. And you've got 3-hour vessel to 3.5. I'm going to ask Dr. Deppel here. Would you have gone to a bigger laser? Because you have a 3.0 vessel, and I always give myself about 70% of vessel size, and it's very safe to do it. Or you think you're happy with a 1.4?
Yeah, I think that my strategy for this would be to some type of plaque modification,
Yeah.
so I can expand the stent maximally, and it's not necessarily maximal debulking. I don't think it would have been wrong to do a 2.0 laser, but then as you start getting farther down into the perineal artery, you're going to start running out of your size, you know. But I think the 1.4, 1.7 laser would have worked fine. You know, but my strategy would not have been to maximally debulk it, just to prep it to get a stent in there.
Yeah.
May I ask a question, actually, of my cardiology colleagues and those who use the coronary stents distally? I do it myself, but in a situation like this, and Dr. Raja, I'll be interested in your thoughts too, do you think, because the bioabsorbable stent will absorb at some point, so is it worth going straight with a coronary stent here and do something that's going to be long-lasting, or like why pick the bioabsorbable versus the coronary stent here?
Can I answer the question? So in the coronary world, when I was doing a lot of bioabsorbable, the whole idea is after 18 months, I'm back to my native vessel. So I can re-stent if I want to. If I do a metal stent. Actually, my question here, actually, I don't know if everybody agrees, why not, you have nice luminal gain, why just DCB?
You know,
then you won't jail the AT. Then you can come back and open the AT to provide perfusion to the foot.
I think that my personal feeling is, first of all, I think that we have data that says both metallic stents and bioabsorbable stents work. So I wouldn't disagree with the choice of either one of those. I think they both work. They're scaffolds. In this situation where you have CLI, your goal is to get as maximum amount of blood to the foot for as long a period of time as you can to heal the ulcer. We've already seen one of the talks earlier today that talked about tibial artery recoil. This looks great now, but nobody comes back in 30 minutes and takes another picture. And I guarantee it's not going to look like that in 30 minutes. And then you're going to sleep a whole lot better tonight knowing that that artery is open and that you're going to have flow there. And so I would put a stent in, maximize your blood flow, and be done with it. And I think you're going to have a lot better result.
But don't you think I need to bring the patient back in a week to open the AT or the PT?
You know, it depends what your angiozone blush is and your wound zone blush is. I mean, if you get great flow down to the foot right now, I mean, you could do like, pedal acceleration time ultrasound and see what the Doppler flow is in the foot. And if you have good Doppler flow, you may not need to open another artery. What I do for all these patients is I see them back every 4 weeks until the ulcer heals. And not to do any wound care, but to monitor the patients, because the wound clinics don't pick up on if the subtle changes of the ulcer getting bigger. But if I see the ulcer getting bigger, I'm suspicious that it went down and I bring them back to the lab. But I see these patients every single month until the wounds heal.
I'm a bit confused. In the prior presentation, we are so strong about not putting metal in the SFA, and all of a sudden, I feel that most of the audience right now are in favor of a stent. And respectfully speaking, I mean, I don't know if by a show of hands, who will put stents in this situation? It looks fantastic, in my opinion, and I wouldn't put a stent. I think the way I will do this, if the patient has a good wound follow-up, I think this is going to be better if he leaves it like this. If the wound starts turning south or stalls in healing, you can come back, and it's not going to be as difficult technically as it was today. The artery is already open. Maybe it's going to be restenotic. You can always go back. I think in this case, it's much better not to put a stent and go back early than putting a stent and jailing endovascular situation in the future.
Number one, Luis, then you're going to accuse me of doing more needless procedures.
No. By the way, I'm 100% on your side on the presentation before.
But number two is that we have randomized data comparing drug-eluting coronary stents to plain balloon to bare metal stents and a bioabsorbable stent to plain balloon. So we have randomized data that in this location, stenting is the best option. I mean, we have randomized data. You can argue that with the SFA. If you put a big full metal jacket and it goes down, where you're going to put your bypass, et cetera. But typically, you're not going to bypass into these zones. And where these stents are most effective is in the proximal tibial arteries, and there is randomized data that this is the most effective way to do it.
Actually, we never really saw the foot picture. Dr. Raja, what was the foot like, the pedal flow, baseline?
The planters came back.
There is a very diseased, I can show you. It's a pretty diseased, very small dorsalis pedis. which kind of collateralizes right distal to the ankle.
Okay.
And this patient has a very severe microvascular disease as well. Go high again.
The biggest problem.
Well, this is the lifeline he has, the maximum blood. And as far as, in my experience, what I think is when somebody like this with CLI, single vessel, I would like to make sure that it doesn't occlude. It looks pretty now, but we have seen again and again that it occludes again, and next time, patient probably had a gangrene, and then you can't save anything.
But
So I
Nelson,
think
to
this
your
is the
point,
perfect place to put some kind of a scaffold.
Actually, very good
But
discussion.
bioabsorbable, excuse me?
Yeah, I'm not against bioabsorbers. My point is that if this is my patient, I would bring him back in a week or 2 weeks and open the AT, PT, right? Because if you have a gangrene down there, right, maybe if it doesn't work, then you have to go PDVA.
but my point being though is that we have no test to do on the table right now to say that you've done enough and that you may or may not need to bring them back. That's my argument. Is so it would be great to do this case right now, put the stent in, do some kind of magic test and say, yes, we've done enough to heal that ulcer and we can stop, or no, we haven't. We need to bring them back in a week to fix another artery. That's the problem. We need some kind of test that we can do right now to show we've got perfusion to that ulcer bed.
But I would argue that if you have SAD, small vessel disease, even with that perineal open, he's not going to do well.
Well, they're probably going to end up needing a DVA.
Yeah, that's what I'm saying.
Yeah, I don't disagree
So-
with that either. But again, that's why I see him back in the office and make a clinical decision. But I wouldn't disagree with having him come back either.
Yeah.
Yeah, let's take a look
Okay,
at the foot.
take a look at the foot. Oh, very nice
Go
perineal.
to the foot now.
Yeah, very nice perineal. Yeah. Okay, this is the most important picture here.
No se mueve la pierna, señor Portito. Tomamos la fotografía.
Can you mag that out a little bit? We can see the whole foot. We're not seeing all the toes and stuff. I want to mag it out a little bit.
Remember, he has CKD.
Yeah.
Okay, here we go.
Can you go? Yeah.
How much
Go to
dive you have used so far?
Go to 17 or 19 inch.
45 cc contrast so far.
Yeah.
Is this good or you want to mag it?
Mag it some more. Go
You
to
can mag
17.
out farther away.
17
Little
or
bit more, no?
19.
Yeah.
I'd move that tape
Here
out
we
of the
go.
way.
Here.
Wait.
How does the maximum you could get? Yeah. Oh, I would go. I'll
So you
open
can
the
see
AT.
that-
You did open the AT.
I wouldn't disagree with you. I wouldn't
open
disagree with that. But again, we don't have
Yeah.
any tests that would determine that that's necessary or not right now. I think you probably might. I think that some kind of perfusion imaging on the table would be helpful. You could try and do PAT right now, but that's probably not as reliable an acute procedure because the vessels are negatively remodeled distally. But we need better imaging to determine whether we've done an adequate amount of revascularization at the time of the procedure.
But I don't think anybody would fault if you just stop here, open a perineal because you got CKD.
Correct.
Right?
Correct. I
Push
agree.
it to kidney failure, it's going to be worse for the patient.
Not bad.
Yeah.
I think it's perfectly acceptable to stop right
These are
here.
the final images of the foot. As I said, very severe small artery disease, but definitely it will improve the flow by opening the only vessel we have. And I feel good putting this stents.
Yeah.
Yeah,
And
the
I'm
only
hoping that they stay open until he heals.
the only choice I would make between a bioabsorbable stent versus a metallic stent is if I'm going to do in a bifurcation zone, I'm going to use metal because you can mold metal and do a bifurcation stent technique rather than trying to go through plastic and crack the stent struts. You don't get quite as good a result when you're doing bifurcation with plastic stents.
Definitely.
Wow, great job.
So I think this is the last image I have.
Yep.
We really had a great time showing these cases done in our lab, and we have a very strong CLI program. We run inpatient and outpatient, and we see quite a few of these cases, and more technology is better for us, and actually better for the patient. So we can provide them a better care and hopefully long-term good outcomes.
Thank you, Dr. Raja.
you very
Great
much.
work, great work. Very good work.
Thank you.
Thank you.